For those of you in the back, if you want to go ahead and shut the doors and grab a seat, we're going to get started on our talkback session. My name is Lori Hack, and I'm the moderator of this session. It's my privilege today to share with you some of the thoughts in our talkback session of the folks who are on the ground floor of meaningful use. And meaningful use, as we've heard today, I believe is part of the key components in the building block for quality. As Pam mentioned in the very beginning this morning, we're talking about the road to quality. How do we bridge our current condition to quality health information exchange? And to really do that through the building blocks, as you were, of health information exchange, really requires, I believe, the ground floor information to be there. We've heard a lot from our various speakers today. Secretary Dooley talked about the groundwork that's being taken place, even in rural counties like Tulare, where she lived, to help provide that data where it's needed for patients to improve care directly. We also heard from Pat Powers about improving health care in California using population health data that is now accessible with electronic health records. Dr. Kaiser talked about the example that if we are going to provide data about patients, perhaps it should be done in the language in which they speak. And with LA County, one school district recognizing 135 different languages, I wonder where are we at with the electronic health record and its capability at that very minute level to offer 135 languages in the pull-down menu you have to complete in order to receive the meaningful use money, right? And I know some of you know what I'm talking about. So this afternoon, for the next about hour, what we'd like to do is have the opportunity for you to hear from the ground level just what's been happening at that very basic understanding that we believe that every provider is going to have an electronic California Rural Health Information Network, or CARIN, as we all know it, which is dealing with all of the implications of EHRs and health information exchange in the rural market. So we have quite a big balance today of information from folks who've been there at the ground floor who can talk about those things that we've all heard about in terms of EHR implementation and just where we are today. So I'll turn it over to you, Mary, if you want to give us your perspective.
Thank you very much, Lori. Can you hear me? Yeah? Just as a little bit of a backdrop, the Regional Extension Program was launched just about 3 years ago, and it was part of the HITECH Act, and about $770 million was allocated to that program across the country to 62 different regional extension centers with the goal of helping 100,000 primary care providers achieve meaningful use. Stage 1. California received grants for 4 regional extension centers to basically support 10% of that 100,000, so 10,000 primary care providers. We have been working as a group diligently for really the past 3 years now, reaching out and helping providers understand what the program was all about, enrolling them in the program, helping them select an EHR and implement that EHR, and then help them achieve meaningful use stage 1 and get their EHR incentive dollars if that was applicable. Across the country right now, the program as a whole has achieved its 100,000 objective of EHR adoption and is around 45% of the way through for meaningful use. California looks very similar to that. We have just about 10,000 providers who have adopted an EHR under our program, so we've met our objectives, and we have about 4,500 who have achieved stage 1 meaningful use, and the majority of them who qualify for the program have applied for an incentive and have either received it or are in process of receiving it. So we're doing really well. It has been really hard work. And I'll speak a little bit just about LA County now. High Tech LA is a rec program that is to serve 3,000 providers in LA County, of which you probably know we have about 10 million people in LA County. As Lori reflected, we have a very, very urban population with a high ethnic diversity, and it offers its own challenges. And so we also have an extremely high population of Medicaid and uninsured in LA County. So in our mix, we have about 30% of our providers are Medicare providers, and the other 70% serve Medicaid and the uninsured. And the two groups that we've been working closely with are the clinics, of which there are about 65 community health centers that we serve, and then the rest are solo practitioners in mostly one provider offices, and so a lot of small practices. In order for us to achieve our numbers, we have had to over-enroll considerably, and especially on the Medi-Cal side, many of the small Medi-Cal providers are not moving forward. They're in a wait-and-hold pattern, or they may not move forward. They don't necessarily are able to get incentives because their Medicaid panels are so small, and they are struggling with thinking about EHR adoption. But of the 3,000, we have over 2,000 Medicaid providers who are very much on board and are leading the adoption effort. EHR adoption, we have 45 different EHR vendors we work with in LA County, so as you can see, there's quite a lot of EHR vendors out there, and everyone has a different approach in terms of how they design their software and expect it to be implemented, which affects how one practices in an office. So we actually have been very successful in achieving EHR adoption, and we thought that EHR adoption would be the hardest part, and meaningful use would be, stage one would be the simplest part, but it's actually been the reverse of that. EHR adoption has been more easily accomplished, and 90 days of meaningful use has been very difficult. There's particular measures that are very, very difficult for provider practices to implement. So I think those are some of the things that we're seeing right now. I can speak more to lessons learned as we get into the conversation, but that's just the sort of an overview of what we're doing in LA County.
And so thank you, Mary. And I think hopefully the panel will discuss a little bit about some of those specific issues, because if you are unfamiliar with the meaningful use measures and just how simple they sound, but how difficult they are, and then how we build off that to actually health information exchange and population management, I think we've got a road to hoe there. Raul, maybe you can tell us a little bit from a broader perspective what's happening at the state level.
Sure. Lori, as you mentioned, I am the chief of the Office of Health Information Technology, and my primary responsibility is really to administer the Medicaid Electronic Health Record Incentive Program. For those of you not familiar with the program, it's a federal program under the HITECH Act, which is set to encourage providers and hospitals to adopt electronic health record technology and become meaningful users of that technology through the payment of incentive dollars. There is some eligibility criteria, primarily a 30% Medicaid patient volume if you're a physician or an eligible provider, 20% for pediatricians. The job seems like an easy job. As a matter of fact, I was told when I took the job, it's going to be the easiest job you'll ever have. How hard is it, to give away money? It's really, walking around with a wheelbarrow full of money. Go ahead and give it away. Little did I know that we had to get a state Medicaid HIT plan approved, that we had to develop a state-level registry, that we had to understand what the final rule said and interpret what CMS's interpretation or intents were in that rule. It was a rocky road. It really took a lot of work with our stakeholders, with our partners, the regional extension centers, the provider community, to build a system that would allow providers and hospitals to attest via a web portal, and then allow us to review the qualifications and initiate those incentive payments. It went beyond that, though. It wasn't just about getting a system up and getting providers to come in. We really wanted to see how we could leverage this federal money and get the greatest number of providers to participate. Because in the end, as you mentioned, Lori, electronic health records really are the foundation of information exchange. That's how it's going to transpire. Dr. Dickey, who is with Office of Health Information Technology, really put his thinking cap on and came up with some very novel approaches to pre-qualifying providers and clinics, rural health centers, so that we could be proactive in engaging them to apply for the incentive program. The regional extension centers really helped us reach out to those individuals as well. Communication was fundamental between the department, our stakeholders, and the provider community. We developed a group module. We were one of the first states to actually allow providers to qualify using group aggregate data. This was seen as a best practice by CMS, so a real big accomplishment for us, and really allowing a greater number of providers to come in and qualify for these incentive payments. Again, working very closely with everybody, we were able to message out. We were able to get this program implemented. It hasn't been easy. There have been challenges, and the feedback that we've received from the provider community, from the regional extension centers, from the provider associations has been instrumental in helping us remedy some of those issues and address policy concerns as well. To give you an idea of the success of this program so far, just for the Medicaid incentive program, we have paid 8,500 eligible professionals. We have paid 900 AIU payments, 933 meaningful use payments. We have paid 207 hospitals AIU payments and 83 meaningful use payments. That's a total of $563 million that we've paid so far. That doesn't include the providers who have already attested that are still under review. Other Medicare providers in California, 2,854 eligible professionals, 219 eligible hospitals, 8,531 Medicare Advantage providers, a total of $620 million in incentive payments to those providers. Total it up, $1.2 billion in incentive payments to California providers for the adoption of electronic health record technology. I think that's a great start. We have a long way to go. Lessons learned through this process is that sometimes our biggest accomplishments or efforts, i.e. establishing group eligibility, introduce a level of complexity that also hampers progress. So we have to work through those issues, but in the end, it's always worth it because we get a greater number of providers receiving incentive payments. The complexity of the final rule. I don't know how many meetings we've had with CMS, we've had with our provider community, our stakeholders, to try to understand, to try to influence and the interpretations of those rules to benefit the provider community. Just a lot of work in that area. The importance of transparency and working closely with our stakeholders, with our partners, has been instrumental. Again, as I mentioned earlier, it's helped us address a lot of the issues that we've had. We talked about challenges. Again, this program isn't just about giving away money, and it's not that easy. From a program perspective, we've already plucked off the low-hanging fruit. The providers that were ready to attest, that had somehow implemented the technology previously, just weren't meaningful users or needed to upgrade the technology. But there's still a lot of providers that we need to reach out. And Mary talked about the challenges that some of those smaller practices have. We have ONC funding going away. And our regional extension centers are out there providing technical assistance. How are we going to reach out to those who have not initiated this process? How are we going to get those who are somewhere in that process through completion and meaningful use? those are some of the challenges. 10% of Medicaid providers who have received incentive payments are meaningful users and received a meaningful use payment. That means 90% aren't. What is causing that? We need to understand what the challenges and barriers are and determine how we can overcome those. Again, working cooperatively with everybody to do so. Ensuring providers are able to report clinical quality measures. We heard Dr. Kaiser talking about that. As a state, we have a responsibility, and we look to you in the audience to help us find those solutions. We also have the challenge of preparing for changes in 2014. That means changes to our state-level registry. It means educating the provider community as to what those changes will require. And finally, we have the Affordable Care Act and the impact that brings. We know that we will see a significant increase in the number of insured and the number of individuals enrolled in the Medicaid program. To that end, there's an opportunity for a greater number of providers to qualify for the incentive payment, but at the same time, it's going to take a heavy toll on provider practices. And we need to ensure that they have the tools necessary to address the issues that they will encounter through this transformation of healthcare and this increased population. Those are just some of the little things that we're working on.
Thank you. Yeah, a few minor things that you're working on there. So one of the things that you mentioned, Raul, was you have been successful in issuing about 8,500 Medi-Cal AIU payments so far, and then you said, I thought 700 90-day payments?
900.
900. So some, I mean, pretty big disparity there. Dr. Carpio, maybe you can talk about why that is and what the challenge is.
Well, I can tell you. Well, thank you for inviting me here. Can you hear me?
Yes.
Ultimate road to meaningful use has been rocky and hard, but I think in the end has been being successful. Not because it's pain, but because it's driving us to where we want to be, is to be able to use the technology that we have and guide us to better quality to our patients. So just to give you a little bit of context, is we started the road of electronic transformation in 2009. Well, actually it was 2007, and we implemented the technology in 2009, April of 2009. We have 28 sites, 134 providers, and we had like 138,000 patients that we serve in all our locations. So the advantage of being born into the electronic technology a little bit ahead of the act that enacted meaningful use is that we were able to kind of get ready for it before it was the actual law. And that is, I think, is lesson learned number one. Do not procrastinate on these kind of things, because definitely that is going to be extremely complicated for you to do that. And that has been part of our mantra. So through the years, in 2009, then we implemented the technology. We did it in waves. And by 2011, when we decided that we were ready to use the first year AIU, then most providers were at least somewhat comfortable with the technology. So AIU was just fairly straightforward and easy, because we upgraded to the technology that we needed to have to meet the meaningful use guidelines. However, for the stage 1 90-day attestation, then it was a little more complicated, because in the first place we needed to have availability of reports that tell by provider how each of them and each of us were doing. That's number one. Number two, we needed to make sure then that the providers were motivated to do that, not for the sake of having a checkbox marked stage 1 meaningful use, but with a purpose. So this is a tool that will allow us to offer the patients better quality of care. And I think that is how we were able to sell that to the providers. I can tell you that If we started on April 2009, we started selling meaningful use once the law became law. Probably, it became law in July, I think, 2009. So we're talking in 2010, we started talking to all our 134 providers and our sites about meaningful use is coming. Why meaningful use? What's the purpose of meaningful use? And it definitely paid off at the end, because the more people here, I guarantee you, we went to sites in 2012 and still some said, meaningful what? And despite the fact that we have been going to the sites and talking in different meetings, still people didn't get it. And that's why the more you speak, the more you bring that information to the providers and the staff, the better everybody's going to be. And I think I mentioned that it's not only the providers, because in reality, the staff, medical assistants and the nurses are the ones who pretty much carry the load and nowadays on the electronic health record live, because those are the ones who need to click the right box in the right place in the EHR that the system will count as, okay, so this encounter counts for meaningful use or not. So those activities that we did, going to the sites, informing the providers, informing the staff, involving them on the process, helped pave the way to the success we achieved. And then once we completed the AIU for the first cohort of providers, then we had the advantage of working closely with HITECH LA, our rec center, who really helped us get ready for the stage 1 90-day attestation. I can tell you, not because you're here, that without them it would have been very hard for us to pool resources enough to be able to drive the pace that we needed to drive. Make sure that the providers were clear on what workflow they needed to follow to be able to meet our EHR elements that were going to be counted as for meaningful use. They help us project manage the whole intervention, and we were very aggressive despite their warning that, well, we launched, I think, our stage 1 in January 2012, and we said, well, we're going to meet meaningful use by June 2012. And people say, okay, come on, I think this is a little too crazy. But I think the work that we did from 2009 to 2012 allow us to do that, because we did not procrastinate it, because we worked with all the providers and the clinics and the staff, constantly. I visited all the clinics multiple times to make sure that they were aware of what was coming. We felt that those 6 months were going to be enough for us, and it did. So in January 2012, when we kicked off the project, and it was a run. From then on, it was a real run. One of the advantages that we did is we got a consultant who gave us a easy dashboard reporting that will show us by provider and by location how everybody is doing in their metrics, in all the 15 core that are relevant from the EHR point of view, and on the menu metrics. That definitely helped, because then that way we were able to, on a weekly basis at the beginning, and then every 2 weeks thereafter, and then once a month at the present time, every provider, every leader at the clinics that they work, meaning the clinic administrator as well as the medical director at the site, were able to see how everybody was doing. And then I reviewed the reports, and if anybody was not doing that well, or that location was doing that well, then we encouraged the meeting, and we had to review the workflow. And I think that is a third lesson learned, is everything is in the workflow. And if you have a workflow that is cumbersome, that it requires the provider to be in 20 different screens, and it is not on the normal clinical place that makes sense for the provider, ain't going to happen. For example, medication reconciliation for us has been an issue. We had to really not use it as our menu choice because we weren't doing that well in this past year. So definitely the workflow made a difference. So we had to redefine our workflow and send staff and trainers to the sites to make sure that any provider who fall below the metric was able to catch up. And the reception we got, we were a little afraid that the providers were going to snap at the trainer and said, well, you're bothering me here. But on the contrary, the providers were very receptive and looking forward to do the right thing for the benefit of the patient, because again, everything is for the benefit of the patient. And every time I hear a conversation that then we need to meet meaningful use just because it's a checkbox, in reality, we're missing the whole point. It is not the money, it is not, although it's good, I won't lie to you, but it is for the benefit of the patients. So I'm happy to say that our first cohort has completely met stage 1, and we finalized attestation this March 31st. Some of the checks are coming, thank you very much. Now, the problem with meaningful use also is not only that it is an ongoing 6-year endeavor, but it also goes by cohort. Every provider starts in 1 year, and you need to be able to keep track as they go through, and that has been a challenge for us, how we keep track of the providers that are going where. So our approach has been, well, any new provider should be ready to meet stage 1 meaningful use by 6 months. So that's kind of our motto, and then we let our administrators worry about tracking the meaningful use application, the meaningful use payments, and allocating that. But the bottom line is that every provider needs to be able to be ready for meaningful use by 6 months. We know that it will take a year or more for them to attest for 90 days, but at least they'll be ready, and that has been our approach. So I can tell you in summary that it has been a rocky, very active year, and I can tell you for a stage 2, I'm afraid of stage 2 because it's going to be more complicated, and it's going to be more complicated because it requires not only the EHR, but it requires a patient portal, it requires some other technology that most of our EHRs do not include. They are an added expense, and that is going to be, it's going to be hard, I can tell you. We are getting ready, but, I think it's going to be hard.
Yeah, thank you. Good. And I think Dr. Carpio really highlights what a large, well-organized organization in an urban setting with lots of support, how difficult it still is to achieve meaningful use. Margaret, I know you've got a unique perspective and not quite the resources.
Yeah, I don't get invited to a lot of meetings. I tend to yammer on about the rural, so forgive me. I do want to paint a little picture for you on the rurals and their unique situation. You saw many maps of California today already with lots of rural areas, and I represent an organization called CareHIN, and we are 17 of the 35 critical access hospitals in California. Our membership is all the way down in the lower part of the state in Needles, all the way up to the top of the state in Modoc County. Our folks started collaborating together about 26 months ago. About 20 months ago, we got a HRSA grant, and that allowed us to formally come together to collaborate on getting a loan program for our critical access hospitals. They couldn't even qualify for a loan to buy the darn thing, number one. They needed some help figuring out how to go through the vendor selection process, how to buy the thing. And then we started implementing. I wanted to say that the critical access hospital in the rural community is an economic key integral part of the community. And I have a couple facts. 14% of healthcare sector is the economic impact for a rural community. And so if I was a CEO of a critical access hospital, I would worry every night about a variety of things. And one of our CEO leaders talks about the healthcare environment right now is a huge tsunami coming at the critical access hospitals. EHR is one of the things, HIE, Affordable Care Act, accountable care organizations, these are all part of the tsunami coming at these critical access hospitals. And you know, at the end of the day, they've got to figure out how to keep their door open. That's like job number one for them, is keep the door open. And so I'd like to just plant that in your mind. Of our 17-member organization, over the last 20 months, I had to go to a grantee conference and raise my hand and say, you know, we've had 12%, we've had a 39% turnover of our CEOs over this last 20 months. So imagine trying to implement something like an EHR when you've got leadership changes like that going on. You probably know that critical access hospitals have low staffing. They may have 1 or 2 people that are IT people. We've heard about the fact that it's hard to find IT people that are healthcare oriented. Boy, that's really true in critical access hospitals. We've had several turnover of key staff at critical times because they just didn't get healthcare. They knew IT, but not healthcare. Of our folks, in the last 20 months, we've had 41%, though, achieve stage 1 meaningful use, and I'm way proud of our folks for doing that. I also would like to say that when we're talking about EHRs, we're all probably talking about acute care hospitals and ICUs. Well, a critical access hospital, a significant number of our members have acute SNF beds. So in our network, we have 295 acute and ICU beds, and we've implemented EHRs for that. But we've also tried to use that same EHR system for the 494 skilled nursing beds that we have. And as we think about coordinating care across the continuity, the continuum of care for patients, rural has it all. You know, they're a one-stop shop. You don't drive down the street and go to an independently owned skilled nursing facility. You're right there in the community. You may have heard that a lot of our folks are having trouble now having to give back money for their skilled nursing care they've already done. Well, you know, so EHRs and meaningful use, boy, that's like number 52 on the list. You know, it's keep the door open. We're a key part of the community. We've got to keep our doors open. In the face of all of this, our organization has tried to stay ahead and say, you know, we can't just think about today, we have to think about tomorrow. We have to think about 2014 and what's coming up. We know we're going to have more mental health people because there's going to be more access, supposedly. You know, the benefits are supposed to increase. Well, you know, we have trouble recruiting primary care providers. Where are we going to find mental health providers in our community? How is this going to happen? The accountable care organization phenomenon has really hit rural very hard. The feds did us no favors. We couldn't qualify for any of the programs, and so our organization has worked very, very hard to figure out how to go around that. HIE and EHR is a key piece of that, but there are other things that are needed as well. And through the generosity of CHEC, our organization was finally awarded a grant in the data analytics piece, and we are working right now to develop a clinical data repository for our rural members, which will take information from an HIE and provide them with all of the clinical data reporting that they need to do for an ACO, and provide an MSO services, care coordination training, patient engagement tools, and we're developing all of that initially with the CHEC grant, and we'll be rolling that out to other rural communities. So for rurals, EHR and getting that up and going, achieving meaningful use, finding an HIE that they could even afford. They had trouble affording, you know, turning on the switch for an EHR. Now they've got to figure out what's the right HIE solution that they need to worry about that will fit them, that they can sustainably continue to pay for. This is a continuing challenge for them. It's not just pushing data back and forth. When rural patients go to a tertiary care hospital, they go a 3-hour ride. It's not down the street. So when those folks come back to the community, that communication has to be key. And they absolutely cannot lose their patient to ACOs, urban ACOs, because it will shut the door. And so these are the things that rural worries about, and why I don't get invited to many meetings.
That's great. Well, and Margaret's here at our request because we really do want to have a discussion, and I open it up to the audience to ask questions of the panel or make some comments about what's happening in your community. I see some of the service partners who've been involved, the local extension centers, and maybe you want to comment or ask questions at this point. And I hope we have some mics out in the audience. Ready for that? Dawn, thank you, in the back. Any comments from the audience or a question for the panel?
There's one over there.
Elsa.
Can I just try doing this?
Here, come and grab this.
Thank you. This is a question for Margaret primarily, I think. Margaret, given your comment that the feds did us no favors because we couldn't qualify for any of their offerings, how do you have a voice? How do you create your voice? And you're clearly doing it yourself. And if you could look ahead 5 years and say, thank heavens X, in addition to the check grant for analytics, what would you love to have happened in that interim 5 years? Who would you like to have paid attention to realize what in order to make what reasonable for you?
I believe that with particularly the Accountable Care Organization activity, first there was a minimum requirement of 5,000 Medicare beneficiaries. Well, if you're one little critical access hospital, you got to be kidding, really? We don't have 5,000 people in the community. So for the critical care access hospitals, we had to figure out a way to band together. And rural is really great at collaborating. Boy, it's in their blood, and thank God for that. So we had to figure out what rural needed, what infrastructure needed to get built, and what could we do that would be sustainable, because God bless all the money, and thanks for the $2.6 million we got for AIU payments. We appreciate it. But we all know that this grant money is going to go away, and we're all trying to figure out, can the HIEs keep going, and how can we pay for them? And similarly with the ACO development. So we had to look and get our national partners. We formed a national rural group. CareHin did. We started getting people around the country that got the innovation grant and said, you know what, we got to figure out this ACO thing, or we're all going to lose our patients. What are we going to do? So it's collaboration and figuring out what can you do without grant money, and how can you make that happen?
And I think a follow-up to that then, from your perspective, and I'd be curious, Mary, from all of what you've seen, given the numbers that Raul mentioned about the AIU, which is simply buy something or produce a piece of paper that shows that you've purchased something, versus really the success of implementing and demonstrating that. Do you think that this whole process is just a grant grab, or do you think this is truly a transformation of using EHRs? You can't answer, Dr. Carpio. We already know your answer.
So yeah, I think it is not a grant grab. I think that once a provider begins to adopt an EHR and does apply it into their clinical practice, they see the benefits of it. And I think with the coordination of care requirements that are coming forward, you're not going to be able to do it without technology. In addition, in terms of the Medicaid landscape, with the movement of so many people coming from the uninsured ranks into the Medicaid program, that's going to just heighten the need for the ability to use information. And then, for example, LA Care, of which my program is a part of, the Duals Demonstration Project, the SPD populations. If you look at the requirements laid out by the federal government, of which the state governments will move this way also, they are mandating the use of HIT. You have to use HIT in order to coordinate care all the way down to the home, because what they're really trying to move through is limiting readmission rates into nursing homes and into hospitals. So I think it's a movement. I mean, if you look at the just on the PCP level, there are 300,000 PCPs in the United States. With this one program, we'll shift 33% into meaningful use, stage 1, and possibly even as high as 50. So once you reach that tipping point, there will not be any turning back, in my opinion. I do agree with Dr. Carpio. I think stage 2 is hellacious. I mean, when I look at what's going to be required for stage 2, and just from where I sit, the fact that the on-site technical assistance has been so important to helping providers move forward that aren't in large entities. That's the big thing, is that on-site technical assistance is going to be needed going forward for stage 2, and we're going to have to figure out ways to find money to be able to make that happen, I think.
And I believe those organizations are more like cattle prods also in a way. You have to show the way. You have to keep encouraging people to keep stepping forward as we move from fee-for-service to fee-for-value. You know, if you're not on board that train, your doors will shut. And it's almost as simple as that. To create an organization that can support that, not only with the technology, but the training and how to do the workflows and all of that, it's absolutely key. And the big question is, how do you pay for this services organization that you may need, your organization may need to help you? Because you can't do it, each one create the same thing. That's just silly. It doesn't make any economic sense at all.
The only other comment I would make that I think makes this a foothold is the fact that I think someone was referencing earlier on the amount of money that each and every one of us has to now pay out for our own health care. And as we become, you know, much more able to shop and experience health care, we're going to mandate the use of information. So we're you know, the stage 2, when the portal comes in, that's going to just drive the consumer usage of this information. And, you know, you can even look at the exchange. The exchange, you know, allows us to start shopping for things, and this price comparison all the way down to looking at your clinical record information, we're going to mandate it. So I think that's the other train that's going to leave the station, is in terms of the patients that are going to want to utilize this information coming out of this technology.
Raul, do you see this as a grant grab, or are you agreeing with these
I hope not.
All right. Other questions from the audience? I think Lynette, and then I can't see who that is in the middle. Oh.
I can talk really loud, I think. Two opposite questions. One, what are the measures that have been the hardest to achieve in meaningful use? And the opposite, what are the measures that have made the biggest clinical improvement and outcome improvement?
So let me repeat that, because that's a great question. Number one, what is the hardest meaningful use specific measure that's been difficult to achieve? And then number 2, what are the ones that actually have a clinical impact?
So for us, the tobacco, I think, has made quite a bit of, you know, of impact. You know, I didn't realize how bad we did assess tobacco before this measure was launched, until we saw our baseline. And once we got into the easy workflow for the provider to meet that metric, boy, you know, that was fairly easy to do. You know, it's pretty straightforward. So I think that so far has made the most impact. You know, our health education teams are doing more smoking cessation forums in a month what they did in a year, you know, months prior. So definitely tobacco has been, you know, not only the one that has the most impact, but also has been the relatively easy to meet, because you just need to put it into the workflow, in an easy workflow, and then from then on it's just straightforward. And now the most difficult for us has been that we control is medication reconciliation, as I mentioned on the menu. A little bit that has to do with the workflow that is too cumbersome on the EHR that we're using to be able to implement. We are making some modifications, so we will be able to then make it easier. And that is our priority for 2013, to be ready for meaningful use stage 2. However, on the state side, I think the whole issue, and it's going to be a meaningful use stage 2, the whole immunization registry and cancer registries, those, the state needs to really create a system that will help us, select that one, as a way of meeting that one. For this year, for example, immunization, we couldn't use it. Well, we use it, but we exclude it because, the system is not in place to accept an interface. But the state needs to assume leadership on that one. And I hear that, they're planning for it, but, we want to see that in reality comes to life in 2014.
The other ones, anecdotally, we've heard, it's especially in the small providers. We serve a lot of the clinics and then the solo practices. The ability to do more preventive maintenance around a population. So, for example, diabetes. We're seeing the ability, even some of these really cheap EHRs, less than $50 a month, can print out a report of all your diabetic patients, and then you can do preventive management. And we've seen some of the providers go down that path, and that's really been really fun to watch, that kind of engagement. The other measure we've heard has been difficult for a lot of providers is the clinical visit summary, and then how to just engage the patient, and whether they really want to engage the patient by handing them their visit summary and giving it to them to take away, because they might have to answer a lot more questions. There might be notes in there they don't want them to see, those kinds of things. So, it's basically giving somebody their medical record, and that's been a hard one for some of the groups to achieve.
Can I springboard off that question? Do you have a report on which of these meaningful use criteria are being met? I mean, in order, ranked, and statistics, basically. And I would suggest that if you haven't, you might do it. And if you did, that it might help industry, help the clinics and hospitals comply.
I would like to say that for rural, having physicians rotate in and out, training, when you go live in a rural hospital, one of our hospitals had the trainers there for a whole week, and they did not have one admission that week. And so, the trainers went away, and then the next day there was a traffic accident, and they had lots of patients. So that's problematic. The interface piece not working with the labs, oh my God. I don't know how they're managing to do that. Medication reconciliation in the hospital is a nightmare. So I will say that. I will also say that the vendors way oversold their products to many of our clients, and they need to be held accountable for that. I don't know who's holding them accountable for it, but I'm a little tired of it, frankly.
And to answer we haven't done that across the population of 3,000, because what that would require is this tool that would lay on top and look at every single meaningful use measure for each provider. So we haven't been able to do that, because what we typically are engaged out there in spending the money on the on-site technical assistance. So we haven't. Now maybe that's something we could take back to the Office of the National Coordinator and see if they could do something more like that. But it's an interesting point.
I can tell you that for us, the reports has been sent, because providers don't want to see red.
Right.
And when you put all your providers in a location and you see, green, 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 red, oops, what happened with Dr. Carpio, and then it's not what happened to me, it's what other people are going to think about me. And that, I get calls and said, I'm not meaning the reports will be wrong. Well, so let me show you. Let's go, and I review with them a sample of 3 patients. I said, let's do this encounter. And then we go to the counter. Oh, I forgot there. Okay, and then let's see another one. Oh, yeah, it's true. I was too busy. So after I show them 3 for the next month, they say it's not coming up as fast as I wanted to. Well, it's a percentage thing. So things take a little while. If you had 1,000 in the denominator, doing 1 at a time ain't going to get you to 50, in a month. So it's going to take time. But I agree, the reports, at least in our big medical group, has been sent, because that's the way that providers and staff get motivated and into, okay, so let's do the right thing.
And just before we close out, because this is on the next question, that is, because this is my personal favorite, the clinical summaries has, in our experience, and I'm looking to the other service partners in the area, regardless of the EHR, and each of them have their own little tricks. Yours does have an issue reporting tobacco. Clinical summaries, the fact that you have to print a piece of paper to give to the patient, whether it's in their language or not, in order to pass the fact that you have an electronic health record, is beyond ironic, right? And we had a number of providers on December 31st where I did not want to spend my New Year's Eve, but was helping them print pieces of paper to try to get that number to pass the percentage it needed to, when every other clinical component of what they did in their practice did pass already. So that is one of my personal favorite ones. Thank you, Lynette, for opening that up. Karen, you have another question back there?
Good afternoon. One kind of follow-on question. Do you see the role of the HIEs turning into more service organizations? So the great example you did about the clinical summaries, being able to provide those electronically or in a consolidated way to consumers, given how consumers are traveling, of course, across providers, and so that the consumer doesn't have to have the exchange at each provider, but rather could have services from the HIE that would really lend and speak to some of the data portability, particularly in meaningful use 2 and 3.
Mary, you want to address that?
Yeah, they're much more competent people to speak up about HIE than I am, but the two areas that we see from a health plan perspective, actually, is the patient health record or patient portal that would hang off the HIE, because just like you said, if you're mobile and you're going across, you have to access 5 or 6 different patient portals to get your health information. So really, if that could be lifted up into the HIE environment and hang one off of there, along with the personal health record, mandated by exchange, that could be something. And then the other thing is there is a potential, LA Care sort of interested in, could you hang off, case management, population management off the HIE and utilize that, across the population, and then rent that out possibly, something like that, so everybody doesn't have to have their own. That might get you some economies of scale. So those are the two things that, we sort of think might be possible down the road.
Margaret, are you?
Yeah, the tool that we're developing through our data analytics grant will do a lot of that, and we're developing a web app, an iPhone app, and an Android app so that patients and providers can get that information out of our clinical data repository that gets hooked to an HIE. So it's downstream. I don't know if HIEs will be able to do the whole scope of services, or whether it'll kind of spin off like our organization is thinking, that will provide this piece of the needed puzzle.
And Dr. Carpio, I know that's sort of your next step. With your population, do you see them utilizing a personal health record, taking their laptop and logging in and so forth?
I mean, depending who you ask in our organization, you're going to get a couple of different answers. The majority of our patients are uninsured. Some of them don't have, broadband at their homes, but pretty much quite a bit of them has cell phones and smartphones, and we feel that may be the way to get our patients to access to their records. We already started the process of getting email addresses, just as a proxy of how much access do you have. And currently, we are barely at 35% of our new patients. We're getting an email address, a valid email address. Now, our next step is, are we getting any more just because we are not asking enough, or if a patient says no, do we probe or not? So those are details that we need to work a little bit. But my sense is that if we can reach 50% of our patients that way, at least at the beginning, and then we drive it from the provider end. So this is how we communicate to you? Do you have any access? Do you have any abilities to do that? Then we will be able to get there eventually.
Yeah, and to add on to that, you know, the other thing, the coupling of the EHR information and telehome is going to be important. For example, in the duals population, one of the requirements is that you can actually monitor and pick up information that's going to feed that EHR. So if you think about an iPhone, for example, being able to attach something that would take your blood pressure or be able to do an EKG or whatever it might be on a particular disease state, and then in addition pick up that information and feed the clinical record, that's, you know, CMS is pushing for those kinds of concepts. And so I think the ability to use the mobile devices out there in multiple ways for any type of population is going to be something we're going to have to move towards.
Great. Comment, Walter?
Oh, thank you. I have heard grumblings in the medical community among small office practitioners or smaller provider organizations that the Meaningful Use program is going to drive them out of small office practice into larger provider organizations, or that it's going to drive them out of taking care of Medicare and Medicaid patients. In your experience in implementation of the Meaningful Use program among both large and small organizations, do you feel there's anything to that, or are those just grumblings of resistant providers who are finding this difficult, but in fact do you believe that it will lead a significant number of small office providers out of small office practice or out of caring for Medicare or Medicaid patients?
So I'll make a comment. LA County, I think, has sort of an interesting spin on it because it's got so many immigrants, and so a number of the, you know, the huge ethnic diversity brings in a lot of providers from other countries who are very able to set up their own practices, and they know what it's like to be an entrepreneur in a single shingle practice, and so I don't think you're going to see that movement. The other thing is don't forget in the market here, you've got this IPA structure that wants to continue to survive, and you've got the MSO structure that wants to continue to survive. And so they're going to fight hard not to end up with everybody moving into large group practices. So I think there's some push dynamics against that movement. The other thing is that technology might be expensive now, but it's not going to be, because, you know, as adoption happens, you spread those fixed costs over a huge number of entities, and your per unit price drops. And, you know, we have examples of that already. You know, one of the vendors we negotiated contracts with, it's $50 a month. That's affordable for a small practice. It really is. Now, and then when they go to this next stage, those pieces of software are already integrated. Now, it's not a bells and whistle type of product, but it says get the job done. Yeah. The other movements I can't really speak to about, you know, our graduates out of, you know, medical programs, you know, that kind of a thing.
You know, that's an excellent question, and, you know, we have heard, you know, some of providers in the community saying that, but I don't think, you know, I think meaningful use is not the cost of that. You know, consolidation has been an issue and a trend over the last few years. And if you go to medical schools and ask, you know, 100, you know, recent grads, very few are saying, I want to be a solo practice, because the dynamics have changed. Now, the few that are, the solo practitioners that are in the community are getting pressures, not necessarily for meaningful use, but care coordination is going to become a way of life. And without technology, as you said, Marie-France, you know, it's going to be extremely difficult to achieve that. And meaningful use is going to help, you know, bridge that gap. So to answer those clinicians, one of my conversation with them is, you know, I think this is the fact of life. You know, in the past we had a phone at our places, our landline. You know, how many households nowadays don't have landlines and they use their cells? You know, because technology has moved, and I think it's just a matter of adapting. You know, adapting to the environment for the sake of improving the care. I think IPAs and health plans will have to pitch in as a way of encouraging, and some already are, as a way of encouraging, you know, adoption, just for the sake of improving coordination, improving the quality of care, rather than just for meaningful use.
And I think there's two components to that as you go from fee-for-service to fee-for-value. There's an IT infrastructure that a solo doc practice needs, and there's an operational efficiency and infrastructure that's needed. How they figure that out is really on them. I've come from a community where the docs just said, you know what, I'm going to retire in 5 years. I am not going down this road. I can't afford it, and I don't want the hassle. And so that's part of the reality too. And in rural, this is probably a little more prevalent than in urban. So, it's a whole different story.
Great. Good. Raul, we're going to let you have some of the final comment here. I think what we've heard in the last sort of round of discussion is that EHRs are really, they're here to stay. This isn't just a grab for the grant. Where do you see the state heading in the next year, other than really afraid of stage 2 and having to prepare?
We didn't say afraid. We're anxious about it. Just like Dr. Carpio here. I think we are committed to supporting the provider community and doing everything that we can to help providers achieve meaningful use. You heard Dr. Kaiser mention the Immunization Gateway, which is a vehicle that will allow providers to come in and submit their immunization information. We'll continue to look for ways for the state to help and play our role in these efforts. To the extent that there are other entities which have a role as well, we'll look to partner and leverage federal dollars to the extent possible. So there is a strong commitment for the state to help. I mentioned earlier that we recognize with the sunsetting of ONC funding, there's going to be a need to provide technical assistance. We need to take a look at what our role is, and how we can accomplish that, how we might be able to leverage some of the infrastructure that exists out there.
Great. Dr. Carpio, any last comment before we close? I see Pam starting to slowly make her way to the front.
Well, I think, meaningful use has been an interesting experience for me personally and professionally. I have been a geek for years, and just bringing over my peers to the environment of IT and seeing ways in which we can really make a difference in the exam room for patients. I think is the purpose and the intention of this incentive and this whole process. So I'm really looking forward to stage 3, really, because in reality that is where the most impact we're going to have is when we are really able to do that. Will it happen in 5 years, 10 years? I don't know. I hope it is less, but I think we need to have more support and more clear guidelines on how to get there.
Good. Well, and I want to thank our panelists today. I think one of the most fascinating things that I've seen since this whole program started is walking into a single practitioner clinic in a rural setting, seeing their stacks of paper and their waiting room filled with patients that they're just trying to care for. And a year later, they're having an electronic system. It's organized. They have lists of the patients that they want to preventively go speak with, rather than waiting till they hit their room or find out they were in the emergency room. And that's really a tremendous thing to see that transformation in 24 months through the efforts of these individuals and many of you in the room. So join me in thanking the panel and your time.